Good morning friends, welcome back to my YouTube channel Medical Classes by Dr. Srinidhi Kumar Acharya. Please don't forget to subscribe to my channel and also please give your valuable comments. You can also visit the playlist. In the playlist, I have provided almost all the topics in a very systematic order. I hope this will be very convenient for the continuous study. My dear friends, today we shall have a discussion on muscular dystrophy. Already in my playlist, I have given so many talks related to muscular dystrophy and other dystrophic disorders. But today we will limit ourselves only for muscular dystrophy. That too, we will limit ourselves for Duchaine's muscular dystrophy and as well as Becker's muscular dystrophy. Now, let us see the first step in muscular dystrophy whenever we are dealing. We should know how to differentiate between myopathy and as well as neuropathy. Now suppose if the child is having muscular weakness, muscle weakness is there, not able to move the limbs, etc. It can be because of a muscle problem or it can be because of a neurological problem, nerve problem. So first step is always we have to differentiate between myopathy and neuropathy. Once it is clear that yes, this is a case of myopathy, muscle related case, then we have to go further in relation to muscular dystrophy. Now, how to differentiate between myopathy and neuropathy? Now, in case of myopathy, the site of involvement is always muscles, whereas in case of neuropathy, the site of involvement is always in the nerves. And there is a junction in the muscle which is called as neuromuscular junction where nerve comes and joins the muscle. Site of involvement is muscle, yes. Now, talking about hereditary, myopathies are mostly hereditary in nature. Most of the myopathy, it may be muscular dystrophies, congenital myopathies, most of them are hereditary in nature, whereas neuropathies are not hereditary much. Some of the hereditary neuropathy disorders are there, like because of vitamin B12 deficiency, etc. Congenital, that is hereditary cause of a vitamin B12 deficiency, are there, but they are very rare. So most of them are not hereditary in nature. Talking about group of the muscles involved. In myopathy, always proximal group of muscles are involved, and in neuropathy, always distal group of the muscles are involved. This is a very important point to understand. Myopathy means always most commonly proximal muscles groups are involved. Okay, in the limbs, lower limb, the gluteal muscles are get affected, calf muscles are get affected. Proximal group is always affected. The distal groups are not affected. Whereas in talking about neuropathies, always the distal group of the muscles are most affected. Proximal muscles are not much affected. Okay, in a neurological problem, the muscles of the digital muscles are get more affected rather than the muscles of the muscles like biceps, triceps, etc. Similarly, sensory disturbance. In myopathies, the sensory disturbance is absent. So myopathy is only related to the muscle. It is not do anything with the nerves. Therefore, there is no question of sensory disturbance. Whereas in neuropathy, motor disturbance may be there or even sensory disturbance may be also there. Next, talking about a reflex. Reflex is either diminished or normal. Muscle is only the media. Okay, what is doing this reflex activity is the nerves. So, if the muscle is affected, reflexes are very less affected. Okay, they are it may be little diminished or it may be most of the time normal. Whereas the nerve is get affected, reflex activities get affected. It may be knee jerk or it may be biceps jerk, whatever. So they are get affected. There will be loss of reflexes. Then talking about the lab investigation, for the myopathy, commonly we will go for some of the lab investigation like muscle enzymes, etc., where we find the muscle enzymes are get increased. Whereas neuropathy, if you go for lab investigation like the muscle enzymes, etc., muscle biopsy, etc., muscle looks normal because the problem is only in the nerves. Talking about EMG, electromyogram, shorter duration and lower amplitude of motor unit will be shortened duration and shortened mean duration and lower amplitude of the motor unit action potential will be seen. Whereas in neuropathy, the spontaneous activity at motor unit action potential and amplitude and duration is abnormal. That means in neuropathies you will have abnormal electromyogram. Okay, whereas in myopathies, EMG when you are doing, so there will be shortened mean duration and lower amplitude and motor unit action potential. That means muscle is degenerated, therefore it is not able to generate that energy. Okay, therefore everything is lower. Okay, but in neuropathies, when you go for EMGs, spontaneous activity at motor unit action, action potential, amplitude, and duration is abnormal. Okay, nerve conduction studies, yes, nerve conduction study shows positive result in neuropathy and normal result in case of a myopathy. Now this is a table which is quite helpful to understand the difference between myopathies and neuropathy. So if a patient comes to you with the loss of action or not able to do the function or weakness, etc., the first thing you have to do is to differentiate between myopathy and neuropathy. So once you differentiate these two things, the things will be very clear whether it is a case of neuropathy or whether it's a case of a myopathy. Okay, now going further, neuromuscular disorders, that means there is involvement of the nerve and there is also involvement of the muscle. So such problems are very common. Okay, although we are telling that this is a muscle problem, this is a neurological problem, nerve problem, but there are so many disorders where there is combination of the two, which is called as neuromuscular disorders. Okay, now LMN, lower motor lesion, lower motor, that means the nerves are coming from the brain and then they get settled in the spinal cord level. From the spinal cord level, the second phase starts. Okay, and that is called as lower motor neuron, starting from the anterior horn cell of the spinal cord segment to the muscle neuromuscular junction. It is called as a lower motor neuron area. So if the problem is there in this area, lower motor neuron area, then the symptoms will be like weakness, there will be hypotonia, there will be hyporeflexia and flexure plantar reflex, because this is a lower motor neuron nerve problem. Similarly, if the problem is there in the anterior horn cell from the upper motor, it is coming and gets settled in the anterior horn cell, and then again the next phase starts. So if the problem itself is there in the anterior horn cell, so then we will have muscle wasting. Okay, muscle wasting. This muscle wasting is not because of the muscle problem. This muscle wasting is because of the nerve problem. So nerve conduction is not proper, therefore muscle is not able to do the work, and gradually muscle undergo wasting. Okay, so there may be muscle wasting, there may be fasciculation, there may be hyporeflexia. Similarly, predominantly distal muscle weakness will be seen, because we know that all the nerve problems will have distal muscle weakness. Now peripheral distal wasting. Okay, if there is a peripheral distal wasting, that is hyporeflexia and sensory involvement and peripheral nerve involvement will be seen, and hereditary neuropathies. So this is quite common, where peripheral distal muscle wasting will be seen. Fatigability and fluctuating weakness. Fatigability and fluctuating weakness. Suppose the weakness is fluctuating. In the morning hours the weakness is more, there is no weakness, but after 2 or 3 hours the weakness is more. Or in the morning hours there is no weakness, but in the night hours he is feeling so much of weakness in the limbs. So this is called as fluctuating weakness or waxing or waning type of weakness. Okay, the fatigability is a fluctuating and a waxing and waning type. This is very common in neuromuscular junction disorders. Neuromuscular junction disorder, for example, myasthenia gravis. Now comes the last one, that is a proximal muscle weakness. Only weakness will be there in the proximal muscles. But when you examine the proximal muscle, bulk is relatively preserved, reflexes are also preserved, but there is a very typical proximal muscle weakness. And in the first table already we have clarified that whenever there is proximal muscle weakness is there, that always indicate towards the myopathies. Okay, predominantly this group, proximal muscle weakness group, so that includes the muscular dystrophies, because it's typically the disease of the muscle. There is no involvement of the nerves at all. So all this basic understanding is for to understand the fact that muscular dystrophies are basically characterized by proximal muscle weakness. Proximal muscle weakness. Now, basic criteria for the muscular dystrophy. Whenever I say muscular dystrophy, there should be some basic criteria. Okay, first we have differentiated myopathy, neuropathy and all those things. Now the basic criteria to say yes, this is a disease of muscular dystrophy, this is a muscle disease. In the muscle disease also this is muscular dystrophy. The muscular dystrophies are progressive in nature because maximum muscular dystrophies or almost all the muscular dystrophies are genetic disorders. So they are progressively increasing disorders. They are inherited disorders. Okay, it is inherited and progressively increasing skeletal muscle disorders, resulting in muscle degeneration and loss of strength. So these things are very, very important. One is muscular dystrophies are genetic disorders. Number two, muscular disorders are gradually increasing, not suddenly increasing or not stable, not like that. They are gradually increasing. They take their own time, maybe years together. Okay, gradually increasing. Third one is definitely they will going to result in muscle degeneration one or the other day. Fourth one, there will be loss of strength. Okay, now the basic criteria for the muscular dystrophy is number one, purely they are muscular disorders. There is no involvement now neuromuscular junction, ASC. No, it is not like that. Purely they are muscle disorders. Number two, they should be hereditary in nature. I am just repeating. Number three, they should be progressive in nature. And number four, there should be degeneration and destruction start at one point of age. Regeneration of the muscle and destruction of the muscle start one particular stage which is progressively increasing and it reaches the severe stage and make the patient totally ambulated. So if these four things are there, then we can say yes, this is a disease related to muscular dystrophy. This is a muscle disease, but it is muscular dystrophy. Now usually muscular dystrophies, the age of the onset and family history, if you see, it is very, very important. You get the family history most of the time. Talking about DMD and all, they are X-linked recessive disorders. So you will have X-linked recessive pattern will be seen in the pedigree analysis. Okay, and at birth, mostly the symptoms are not identified except if it is a case of congenital myopathies. Then at the time of the birth itself, child is having some muscle weakness, neck laxity, etc. may be there. At the adulthood, usually it is identified. As the child get into the childhood stage, usually this is identified. It may be DMD or it may be BMD or limb girdle pattern or shoulder girdle pattern, etc. So they are all identified in the childhood period, not exactly in the infant or neonatal period. At adults, during the adults, some of the muscular dystrophies are there which are identified at the time of the adults, during adults, like limb girdle myopathies or limb girdle pattern or inflammatory myopathies where there will be pain, etc., polymyositis, dermatomyositis, etc. In the older age also, sometimes we will going to get some of the muscular dystrophies like inclusion body myositis, which is called as a distal myopathies, oculopharyngeal muscular dystrophy with eye involvement. So they are all rare phenomena, but as far as the childhood period is concerned, this is not necessary for us. In the childhood period, we know that the two most common pattern of muscular dystrophy is a DMD and as well as BMD, Duchaine's muscular dystrophy and as well as a Becker's muscular dystrophy. Both are actually X-linked recessive disorders. When I say X-linked recessive disorder, that means it is transmitted from the mother. Okay, it is actually the inheritance is from the mother to the male kids. Okay, because X-linked recessive means a male is having only one X and another one is Y, whereas female is having two X's. So although one X is mutated, another X is there which will manage the things. But for the male, unfortunately, there is only one X, and if that X is get mutated, there is no other X to manage this. So what happens is X-linked recessive disorders are most commonly leading to the presentation of the actual disease in case of male. But in female, there runs carrier. Now, just classification of the muscular dystrophies. There are so many classifications of muscular dystrophies there. In the childhood period, muscular dystrophy, they are again classified into muscular dystrophies with muscular dystrophies with pseudo hypertrophy and muscular dystrophy with the atrophies. Okay, in the adult muscular dystrophy, again the classification is with facial muscle involvement and without facial muscle involvement. So this classification is called as Erb's classification. Erb's classification. Similarly, one more type of classification is there, Natras and Walton's classification. So this classification depends upon the other criteria, like X-linked recessive, whether the muscular dystrophy is X-linked recessive. For example, DMD, benign form of the DMD, emerald refuse, so they are all X-linked recessive disorders. Similarly, autosomal dominant muscular dystrophies, faciomuscular humeral form, then scapular peroneal form, etc. One more type is unclassified, where limb girdle dystrophies, etc. will be there. They are unclassified. And one more classification is their latest classification. So like this, these are the two important classifications. One more type of classification is there, like X-linked recessive, severe form, for example DMD, benign form, for example BMD, benign with early contraction, emerald diffuse muscular dystrophy, and scapulohumeral. One more is autosomal dominant, that is facioscapulohumeral, scapuloperoneal, and these are the early onset. The late onset we will have ocular, oculoperoneal, facial, etc. Autosomal recessive, if you are talking limb girdle, congenital muscular dystrophy, etc. Okay, so these are the different classifications. Some of them are depending upon the hereditary pattern, and some of them are depending upon the symptomatology, and some of them are depending upon the status of the muscle. Now we come to Duchaine's muscular dystrophy in detail. This is also called as Erb's muscular dystrophy. Duchaine's muscular dystrophy is also Duchaine, it is also pronounced as Duchaine's and somebody Duchaine, etc. But Duchaine is the correct pronunciation. Duchaine's muscular dystrophy, this is also called as Erb's muscular dystrophy, and this is the severe generalized dystrophy. When I say generalized, all the body muscles are involved, but we should know when I say muscles, in muscular dystrophy it is proximal muscle. That means all the proximal muscles of the body will going to involve one or the other day. Okay, so DMD is most common, which affects the all races and all ethnic group around the globe. Okay, it will not spare anybody around the globe, it will affect all the people. In 1986, G.B.A. Duchaine identified it for the first time. Therefore, he is a French neurologist, hence the name Duchaine's muscular dystrophy is there. Okay, it is also called as Erb's muscular dystrophy. Talking about the incidence, 1 is to 3,600 is the incident, and in general incidence, if you see, 1 in 25,000 population. So incidence is not so less. That means incidence is quite high. 1 in 25,000 in general all over the globe means it is not a small thing. So this is basically an X-linked disorder where only male are get affected, and the reason I told X-linked disorders, mostly the males are get affected, females become carrier. So incidence of the disease in the female population is quite less. There are so many other reasons, even the female may be also get affected, that we'll see. The protein dystrophin, what is the basic cause? There is a protein called as a dystrophin, and this protein dystrophin is absent. Why it is absent? It is absent because of the genetic cause. The gene which is responsible for the production of the protein dystrophin is either absent or mutated or abnormally functioning. Therefore, either the dystrophin is not produced, or if at all it is produced with the bad quality. That means it is not able to render its all normal functions. Okay, so abnormal gene is identified in X chromosome because it is an X-linked chromosome, so disorder. So X chromosome at XP2 locus, P portion in the X chromosome, P part of the chromosome, the locus is 2. There exactly this gene is present, which is responsible for the production of the dystrophin, and this gene, if it is abnormal, then all the problem start. Molecular weight of the dystrophin protein is about 247, and the total number of amino acid which is present in this particular protein is 3685. Now you can imagine the size of this protein and importance of this protein. This is one of the largest protein. Okay, very important protein which is required in the muscle. rendering a very important function because it is a largest protein, and dystrophin, its molecular weight is also 427. So definitely it's a very important protein, and unfortunately this particular protein is not produced properly because of abnormal gene. Now dystrophy means, as you know, it's a abnormal growth. Dystrophy means it is abnormal growth. Trop means nourishment. Okay, so dystrophy means muscle nourishment is abnormal. Muscle nourishment is abnormal. Okay, so now we have got different terms like atrophy, dystrophy, hypertrophy, etc. Atrophy, we know that loss of the muscle mass, okay, muscle cells, etc., or number of cells. Hypertrophy means increase in the number of cells or hyperplasia of the muscle cells. Whereas dystrophy is something different. Dystrophy is something related to dystrophin protein. The outcome or complications because of absence of dystrophin protein is called as dystrophin. Because of the absence of the dystrophin, what actually happens is the muscle fibers are not properly formed. In the muscle fibers, sacrolemma is there. Inside the sacrolemma, two important fibers are there, actin and myosin, which is actually responsible for the contraction of the muscle. Okay, now this actin and myosin, then sacrolemma, so they are able to do their function normally only in the presence of the dystrophin protein. We will discuss later. Okay, now when this is not happening, what happens is the actin and myosin are not formed inside the muscle, and that space will be occupied by some abnormal fat contents. So now muscle will be there without the actin and myosin, the active elements of the muscles. Instead, some unwanted fatty substances accumulated there, and as a result, what happened? Bulk of the muscle is increased but useless. It is not able to do the contractile function. Okay, so therefore the word dystrophin is there. So dystrophin means it is abnormal nourishment of the muscle. Muscle is get accumulated by muscle fiber is get accumulated by some abnormal substances like fat, etc. And that is the meaning of dystrophin. Dystro means abnormal and troph means nourishment. So abnormal nourishment. Now muscular dystrophy suggests many more things than the simple aberration in the nutrition of the muscles. So there is no or very less involvement in the females. I already explained the cause. Normally the females are carriers and males are the sufferers. Of course, sometimes rarely females are also get affected in conditions like Turner syndrome. Turner syndrome actually 45X0 is there. Okay, there is only one X is there. Suppose that one X which is present, that is also mutated. That contains the mutant gene for the dystrophin. Even a female may also suffer with the, DMD. Okay, and rarely it may be transmitted as autosomal recessive type. Usually DMD transmitted as autosomal X-linked recessive type. Sometimes they are telling that it may be also transmitted at autosomal recessive type. Autosomal means male and females are equally affected. So even female may be also get affected. 30% are due to new mutation. Now this is because there is no problem in the previous generation. The problem only started in this generation. The dystrophin gene mutation started in this generation only. Then there is no question of male and female. Anybody can be get affected, isn't it? So these are some possibilities where DMD and BMD can even occur in female. Now some are very severe. Sometimes the DMD is very severe and may lead to death very fastly, while sometimes the DMD is quite slowly progressive and occurs over the decades. For example, BMD, Beckett's muscular dystrophy, is a relatively a slowly progressive disease. And even in DMD also, sometimes the child is having a fast progression of the disease and sometimes slow progression of the disease. It depends upon the amount of the mutation which is happening in that particular gene. If the mutation is totally, if the gene is totally abnormal, everything is abnormal, 90% is abnormal, then definitely disease will be fastly progressive. Now if that particular gene is only 50% abnormal, 50% is working, then it may take some time, slowly progressive. So few are even more not symptomatic until the adult life. There are different types of myopathies are there, dystrophies are there. So some of them are very slow, and some categories of muscular dystrophy is there, like limb girdle muscular dystrophy or shoulder girdle muscular dystrophy, emery diffuse muscular dystrophy, myotonic dystrophy. Okay, sometimes one of the important differential diagnosis is spinal muscular atrophy. Okay, of course, spinal muscular atrophy, it is not dystrophy, but its symptoms at times mimics with the muscular dystrophy also. That should be also, therefore, it should be also kept in the differential diagnosis. Now, in the next class, we will discuss about the genetic etiology and pathogenesis so that the disease can be understood very clearly. Thank you very much.